something to improve it, their quality of life or morbidity may not improve that much. So neurologists, patients should know if they've had these weaknesses which have improved. These are the patients who will definitely benefit a lot from getting some vascular intervention from us.
Right. Okay. So you've described this disease is very dangerous. So how fatal would you say the disease is, and what are the treatments and procedures that one could go through to avert the disease?
See, fatal had vascular disease and the artery completely gets blocked off, then that part of the brain gets no blood supply at all. So the stroke that can be totally fatal, or it could be disabling to the patient, completely paralyzed, completely bedridden, unable to walk, passing motions and urine in bed itself. So that's a very bad quality of life the patient is going to live if they recover. If these patients are picked up early, then they have multiple options, depending on how bad their disease is in the vessel. Now, what the text says that if you have a disease which is around 50 to 60%, you can try medical management, give them good antiplatelets, bring their sugars under good control, and control their cholesterols. But if the patients had recurrent, say, transient ischemic attacks or has had a moderate stroke with good recovery, and the patients had more than 70% block, then they definitely need some intervention to improve the blood flow to the brain. Now we have two options. You can either do, like Rahul said, open surgery, where you can open the carotid artery, cut open the vessel, clear the clot, and then we put a patch. When we cut the vessel, if you suture, it becomes narrow. So we put a patch to widen that area. Okay, that is an open surgery. The other option is to put a stent, like how we put a stent in the heart. You can put a stent into the artery and open it, and that itself can suffice improving the blood flow. Each has its advantages, disadvantages, and what will benefit the patient is the surgeon's choice, looking at the benefits and the risks the patient has. Say, for example, if the patient has both sides carotids which are very tight, 90% more stenosis, 90% blocked, then I would tend to say endovascular would be a better option, because opening the vessel, doing a clamping, closing off the blood supply for the brain for some time can trigger a stroke in itself. Whereas stenting has a slightly better chance when both the sides are diseased. But if the other side is moderately open, then open surgery will definitely be, in the long term, better results.
Right. So are there any precautions or simple tips that people can follow to avoid this disease?
Like, the most important thing. Get your sugars under good control. Have healthy habits. Smoking. If you are or a diabetic or a hypertensive, screen yourself. Get to the doctor. Get yourself evaluated. Like you get evaluation for the heart. Screen yourself for the carotid vessel. If they are picked up early, then definitely you will prevent a lifelong morbid state. If stenosis is picked up early, before anything happens, with medical management, we can definitely bring down the chance of having a stroke. And if you've had a stroke, once the intervention is done, make sure you do follow your doctor's advice. Get yourself screened regularly. These simple things will prevent long-term problems.
Right. You have to get checked for both.
Yes.
Yeah. Now, taking the discussion towards diabetic foot wound care or foot ulcers. Dr. Rajendra Prasad, I want to come to you for this one. What are diabetic foot ulcers, and how common is this among diabetic patients?
Yeah. Coming to first part of the question, what is a diabetic foot ulcer? So, a diabetic patient who is having a decreased vascularity, and then patient who is having a deformity. Deformity is there are bony deformities in the foot of a patient who is having long-standing diabetes, and also another the important thing is neuropathy. So these are the three main causes for an ulcer in a diabetic foot patient. So any ulcer in a diabetic patient who is having all the three or any of these three, so either decreased blood supply or deformity or neuropathy, is called as a diabetic foot ulcer. So do all the patients with diabetes get these ulcers? No. Patients who are having neuropathy, so if there are 100 people with the diabetes, so among them about 60% of patients will have neuropathy. Do all the patients with neuropathy develop ulcers? No, again. So neuropathy again leads to deformity. If the patient doesn't have deformity, definitely chances of ulcer getting is very less. But neuropathy combined with deformity, there is a high chance of patient getting an ulcer. So what are the percentage? Again, coming to the numbers here. So about 60% of patients with a neuropathy, definitely about 20 to 25% of patients do get their an ulcer, which can be chronic and then long-standing and non-healing in their lifetime. So it's a very significant number compared to the number of diabetes in our country, which is being called as diabetic capital. Even Bangalore is also being called as diabetic capital of India. And then again, regarding diabetes, earlier this used to be called as only people who are the elite group or the rich people get this disease. Now this concept is changed, or it's a misnomer. It is not a rich man's disease. It's a lifestyle disease. That's all. So even people at villages are also, they're having diabetes, and then definitely lifestyle and then food habits have definitely changed all over the world. So even with the diabetes, we have got this associated comorbidities, that is especially diabetic foot ulcer. So this is regarding diabetic foot ulcer. And then how common is definitely they do are very common with the patients with diabetes. That too, they are having a long-standing diabetes. So again, explaining a little bit more about neuropathy. Neuropathy is something called as it's a sensation felt in the foot. So it's a protective sensation. So this sensation is a gift given by the God. If it is lost, definitely as a child will come to know, if you touch fire, it burns. Same thing will not happen when the patient has got diabetes. He will not feel his own chappals. Even the chappals falls off sometimes with a severe neuropathy, and then he will be walking barefoot. This is the such severity of the neuropathy. Because of the same neuropathy, you will get deformities of the foot and then ultimately ulcers. So another important cause for this diabetic ulcer, as just I was mentioning, is decreased vascularity. Being a vascular surgeon, we are the people who do take care of these diabetic foot ulcers, even though there are many other subspecialties who do take care of this, like podiatrists. But with a decreased vascularity, any ulcer in the wound, ulcer in the or a wound in the leg will not heal. So what is the commonest cause other than this neuropathy is the decreased vascularity. So definitely this atherosclerosis along with smoking is most dangerous combination for any diabetic foot ulcer. But what happens in diabetics? In non-diabetics, also there is with age there is really atherosclerotic. Otherwise, what I can say is calcium buildup or cholesterol buildup in the blood vessels. But in diabetes, what happens? It will happen even in the smaller blood vessels of the foot. So there will not be good blood supply in the foot blood vessels. So they'll be more prone for this ulceration, and then which is not healing and then turning into gangrene. So because of these are the two main reasons for a diabetic foot ulcers, and then these are the common incidences. And then how do diabetic patients get an ulcer?
Right. Dr. Prasad, how do you diagnose foot ulcers? What are the different treatments and therapies available to treat the initial stage and chronic stage foot ulcers?
Yeah, coming to the diagnostic part, first, not directly going to the diagnostic part of a diabetic foot ulcer. First, we need to confirm many of the patients come to us without knowing that they have been diabetic for quite many months or years, and then they'll come to know only when they have an ulcer, and then they'll come to the clinic with a very badly infected ulcer. So a diabetic foot ulcer either can be infective or it can be ischemic. So another important thing is neuropathic, ischemic, and then infective. So most of the patients come to us an infective. Infective is always the initial part. So definitely infective ulcers can be treated very easily. You have to take away the infected part either by doing the minor surgeries like incision and drainage of the abscess, and then sending that first for culture sensitivity, giving the antibiotics, rest, and then take out the dead and necrotic part. So an acute part of the diabetic foot can be definitely treated easily, but another chronic part, you said how it can be treated. Acute part is definitely easy to treat the infection, and then treat the diabetes. And then again, another word about diabetes. So one common test being done to know the diabetes is called as HbA1c. So it will show us what was the patient's sugar level in the past 1 to 1.5 months. So normal level is less than, I think even every diabetic patients definitely know what is an HbA1c test. It has become a quite common test being done for any diabetics. So a HbA1c, 1% increase in HbA1c will lead to 26% increase in diabetic foot ulcers, and also diabetic foot ischemic ulcers, like something I can tell it as peripheral vascular disease. So management of sugars is quite important in managing the diabetic foot ulcers. Then coming to the chronicity of the ulcers. So why diabetic foot ulcer can become chronic? So one, chronic means they will not heal in spite of good treatment, also taking out the infection, keeping your sugars under control, everything. So here comes the part of another specialist called as a podiatrist. So they do take care of the diabetic foot part with the help of vascular surgeon and also foot care specialist. So here, what will be the reason? So first and foremost reason is the pressure. Pressure is like you'll be putting almost about entire 50 to 60 kg of your weight over the ulcer, and then you'll not feel the pain. So this is the most important thing we are supposed to do. Take out that pressure of the ulcer, and then only we'll be able to heal. So that is called as offloading. So offloading a diabetic foot ulcer definitely heal the chronicity of the ulcer, and also a deformity. A deformity can be because of any bony abnormal structures or a deformed toe, or it can be infected bone inside. So you have to take out that infected bone or do some corrective diabetic foot surgeries to heal the chronic ulcers. And then there is one important saying in our textbook. You can do, or you can put anything on the diabetic foot ulcer except the patient's own weight.
Right.
So that means patient will be walking with the big ulcer, which is painless, and then it will not heal just because is not giving rest to it. So this is another important thing: offloading, taking away the pressure out of it, and then correction of the foot deformities. Either it can be bony deformity or it can be pressure offloading. So this is how we can heal both acute and then chronic. I'm not saying we can heal. So I think our two colleagues will also definitely agree that healing is very, very, very difficult in a diabetic foot, chronic diabetic foot ulcers. They keep on coming back to us. Healing is only a small part. We are supposed to prevent it coming back. That is most important thing.
Right. So how should one effectively care for diabetic wounds or ulcers? Like what is the role of patient here so that he does not come back?
Yes. So we always hope the patient does not come back to us with a diabetic recurrent foot ulcer. Yeah, definitely patient role is really important. One is he's supposed to take care of his foot. First is prevention. He should take care of foot properly. It will start from inspection of the foot. That is, he'll have to check his foot once he get out of the bed, or once he takes his bath, and then check in between the toes, check for the ingrowing toenails, and then heal for any cracks or dryness of the skin. This is one. And then many of the patients, because of it's a what I can say, it will affect the entire blood vessels of the body. Most of the patients will not be able to see. Sometimes they'll be blind also. So they'll not be able to see. So they may have to take somebody's help, and then if they may not be able to bend also. Sometimes I would suggest using a mirror to inspect their foot, heal, and then see for the cracks, and then apply good moisturizer to the heel at the night, and then also the entire foot. And also important thing in any of the diabetic foot patient is footwear. Footwear, you should always choose where it has got a very boxy foot. Front foot is really boxy, it should not pointed, and then it is well cushioned. So something like a good running shoes. A running shoes has got a good front, airy front part, and also it has got very well cushioned sole and also inside. So footwear makes a lot of difference in prevention of any type of diabetic foot ulcers. So along with that, most important thing is keeping his sugars under control, And then if he has got a habit of smoking, that needs to be quit. So, and then also regular exercises. So by these simple modes, lifestyle changes, definitely we can prevent the patient coming back to us with a recurrent ulcers by just taking care of the food.
Right. Dr. Rahul, I want to talk to you about minimally invasive limb salvage now. I want to understand what is minimally invasive limb salvage surgery and how is it different from the traditional limb salvage surgery?
Minimally invasive limb salvage is nothing but using of endovascular methods or minimally invasive methods. It is just like I mentioned earlier that we use angioplasty to treat the blocks in the blood vessels, unlike open regular traditional surgery called a bypass. The idea is usually in critical limb ischemia, the toes or the foot is where the ischemic or the tissues with lack of blood supply will be there. So our idea is to, or our aim is to provide perfusion or good blood supply to that part. So wherever the block is from, right from the abdomen, where the main blood tube which comes from the heart called aorta, it divides into two for each legs and goes. Wherever there is a block, we need to open it up. It can be through a simple procedure called plain old balloon angioplasty, where we just pass the guide wire and a balloon over it and open up the block. However, sometimes despite doing that, there is a chance of it not opening up fully because the blood vessel has been blocked for long, and there are chances that it might open up partially, but it is not adequate for the wound to heal. So in such cases, we pass a stent or we place a stent. So the stent is nothing but metal or a tubular metal which keeps the blood vessel from closing back again. However, it is important that the patient is very compliant with regard to medications post the procedure, because nothing is like a naturally given tissue what we got from the Almighty. Whenever there is a foreign material placed in the body, the chances of reblocks is always there. So good lifestyle and the compliance with medications is important. However, the catch here is it is not about blindly going about minimally invasive just because it is in the fashion. It is important that minimally invasive with acceptable result. So whenever there is acceptable result, or for example, we need, let's presume that below the level of knee, there are blocks in two or three blood vessels out of the 3 blood vessels. And our target is one particular blood vessel. And if we are able to achieve flow through it in a patient who is totally unfit for surgery, that should be good enough. It's not like we have to do bypass and improve all the blood vessels. Like I said earlier also, it is the patient choice and what is good for the patient overall. So when you compare minimally invasive procedures, angioplasty and stenting of the blood vessels, which increase the blood supply to the deprived tissues, causing healing of the wound and salvage of the limb, is called minimally invasive procedures for limb salvage.
Right. What are the if we turn to the clinical outcomes of this procedure, and when we compare it with the traditional limb salvage surgery, are these outcomes better?
It depends. Nowadays, with the improvement in the hardware or the what we call as the armamentarium, which a vascular and endovascular surgeon possesses, the results have been good. However, it is not as great gradually, or I cannot give a blanket statement that endovascular procedures at all levels is as good as a open bypass surgery. So, but it is an acceptable level of patency. I have mentioned you earlier that it is always, which is more important when it comes to a question of life versus limb, then we have to prefer life. And there's something called as acceptable result. A bypass might provide you with what you call as a very long-term patency. Sometimes in the abdomen, we do a bypass. They 95% of these bypasses work for more than 10 years also. And there might be a stent which is placed in the leg, or balloon angioplasty, which is done for the below-knee blood vessels, which might be open up or keep have a patency of about 2 to 3 years also. That is acceptable, because if this patient would have undergone open traditional bypass surgery, his risk of tolerating the surgery and coming out of it would be lower. So the patency rates is gradually catching up, and it also depends on the area. Below knee blood vessels now gradually it is picking up because open surgery to the below knee blood vessels is quite morbid for the patient. And considering that most of the patients have comorbidities, minimally invasive procedure is any day acceptable and is in fact the first line of treatment. It is only if it is not possible, or if it is totally blocked, that we are unable to open up the blood vessels in the below knee segments where even stents cannot be used. The results are very bad. In such patients, definitely bypass is considered, but otherwise a minimally invasive procedure is only the treatment of choice.
Right, right. What are the different diseases that minimally invasive limb salvage surgery can treat?
See, different diseases in the sense blocks, like blocks can be
Yeah.
because of calcium deposition within the blood vessels. This is usually because of atherosclerotic changes, or what we call as the common layman term is lot of calcium is deposited in the blood vessels, or there is a lot of hardness in the blood vessels, is what the patients tell. So this is the most common cause for limb threatening ischemia. So in these patients, it is always better to attempt for a minimally invasive procedure first, and then plan for a bypass if needed only.
Right, right. Now, to conclude our conversation today, I have my last question for right now. One of my last questions, actually. Looking at India for the coming years, currently over 60% of deaths are happening due to non-communicable diseases, and out of those, close to 27% happen due to cardiovascular diseases. Now, this trend is predicted to rise in coming years. How do you think we will be tackling this rising burden? And what would you tell our viewers? How can they stay clear from cardiovascular diseases? And this question is open to the panel, and I want to start with Dr. Rahul.
Yeah. See, the cardiovascular burden, like you said, it is quite high. Now, when it comes to assessment, see, the reason why the title was suggested by our entire team as role of vascular and endovascular surgeon is a vascular and endovascular surgeon is a specialist who is trained and extensively trained and specialized in multiple aspects of treatment of a vascular disease. We are trained extensively to clinically evaluate the patient. Then we are good in diagnosing it. Then we use the necessary investigations which are required. And then when it comes to treatment, be it through lifestyle advice, lifestyle changes advice, or through medications, or through interventional procedures, open procedures, and even hybrid, like I mentioned. See, these are all the things which can happen with one doctor, that is a vascular and endovascular surgeon. So it is very important that we take this message to the general public that whenever they have any cardiovascular symptoms, or even there is any inkling towards it, then definitely they should consider consulting a vascular surgeon first, because that will help in early detection. Many a times, multiple specialists do treat vascular problems, but when it comes to a structured and more scientific way about going about it, then there is no question that there should be anybody else other than a vascular or endovascular surgeon doing it.
Right. Dr. Prasad, would you like to add?
Coming to your question of burden
Yeah.
of cardiovascular diseases and then how we can tackle. Yeah, definitely with the increasing population and then with the increasing younger generation of, I can say, young generation only. So main thing is definitely any cardiovascular or the especially peripheral vascular disease. Commonest cause is smoking. Smoking causes all the problems. Even it will make the patient come to us with the early atherosclerotic changes and then early diabetes. So smoking is the first thing where we can abstain from ourselves and then prevent this burden on the society. So another is lifestyle changes. So hardly we see any patients or the persons younger generation who are into regular activities like. So one is this exercise and then lifestyle changes and also stress. Stress makes a lot of difference, as Dr. Anup was mentioning. Even the stroke, one of the most important cause of a stroke is hypertension. So these are the things which can be really prevented, even like an amputation. So almost in 40 to 60% of patients undergoing amputations are non-traumatic. So it's a preventable disease. So even in India, so even the patients who have got, I can say, trauma, many of the limbs have been saved, but they have been being amputated because of the peripheral vascular disease. Definitely that can be prevented with the utilization of the workforce like vascular, peripheral vascular, endovascular surgeons. So same like this cardiovascular diseases can be prevented or curtailed or kept in control just by simple measures like lifestyle changes and exercise and also food habits. So junk food, definitely nowadays, each and every person, even being doctors, we do eat junk food. So we don't have any options. Sometimes even in OT, we just order for something, we eat that. So even a simple masala dosa is not a healthy food. So we have to abstain from these things and then lead a healthy life and then for a long and then healthy life. So definitely it is in our hand to decrease the burden on the society and also in the hospital. Nowadays, even if you go to any hospital, even though this pandemic is over, getting a bed is very difficult. Just check in any of the hospitals. So it is very difficult to get a bed for acutely ill patient. So if you are healthy with these simple terms, definitely we can prevent many of the diseases.
Right, right. Dr. Anup, over to you.
Like Dr. Rajendra Prasad sir said, most of the problems is related to our lifestyle habits. Stress, stress leading to your habits of smoking, irregular eating, less activity. These, if we can bring down these, lead a healthy lifestyle, do some physical activity, cut down on your smoking, stop it. That will be the best. Alcohol consumption in limits. Then overall, your chances of developing disease and suffering from it can be brought down. Second thing is, we know the burden is going to go up. All you have to do is get yourself evaluated also once in a while. We are seeing a lot of young people coming to us with, surprisingly rare places where they develop ischemia, infarcts, young people having myocardial infarction, young people coming with stroke. All this just is because of our lifestyle and our stress. And, the associated smoking, drinking. So if that can be brought down, and if you get yourself evaluated also frequently, I'd say, if you're a professional who is, type A or a very stressful job, start getting yourself screened by 35 to 40. Get yourself yearly or, by once in 2 years, get a total health checkup. Get yourself screened for, your heart as well as your limbs. If you have symptoms, keep yourself, go quickly to your doctor. Diabetics, don't wait till things happen. If you can get yourself screened at home or with, visit your doctor, you can prevent major complications. You can come early, get yourself treated early, and in turn prevent morbid. That's how I say we could bring down the problem by these small changes. Please stick to what they've said, listen to them, and try to follow what they say. It's always for your good.
Right. Thank you, Dr. Anoop. Now, to conclude this conversation, we are also joined by our three panelists who had previously joined on the other session. We have Dr. Venkatesh Reddy, Dr. Aziz Pasha, and Dr. Hemant Kumar. Welcome again, doctors. Are you able to hear me, Dr. Venkatesh? Dr. Hemant?
Hello.
Right. Dr. Hemant is there. We can't see your video, Dr. Hemant.
Yeah.
Can you please put it on?
Yes. I think the host has disabled the video or something. That's the message I get.
Okay. Host, can you give permission to Dr. Hemant to switch on his video, please? Okay. Now we can see you, Dr. Hemant.
Right.
Right. Thank you for joining us again today. We are also joined by Dr. Venkatesh. Yes, he's also there. So now let's address the elephant in the room. Which is the topic of today's discussion: the role of vascular and endovascular surgery in modern healthcare. From the two of you, I want to understand what is the role of vascular and endovascular surgery in the modern healthcare scenario. Why don't we start with Dr. Hemant?
Yeah. Thank you. I think I heard Dr. Rahul and Dr. Rajendra Prasad and Dr. Anoop very clearly and precisely mentioning about the role of the endovascular procedures in modern vascular disorders, management of modern vascular disorders. Over the last couple of decades, endovascular and minimally invasive procedures in vascular surgery have so dramatically improved and increased in numbers. Almost all disorders are being managed by minimally invasive procedures or endovascular methods. Textbooks have been rewritten so rapidly because of the advent of these newer procedures, newer gadgets, newer equipment. We are able to get much better outcomes in these patients. We are able to get much better results with lower morbidity and mortality in these patients. So there's a paradigm shift towards minimally invasive procedures as regards vascular surgery is concerned. How the presentation of the patients does matter a lot in the management of these diseases. If patients come late with advanced disorders, then endovascular procedures may not be as optimally useful as it would have been if they had come earlier. So it's a paradigm shift. It would be an understatement to say that the endovascular is a new method which is coming to the field, and it is first choice is endovascular. The outcomes, the results, the durability of the procedures has also increased over the last couple of decades. So much so that it competes very well with open vascular procedures, and so they're here to stay, and they're likely to become the first line of treatment in almost all of the vascular disorders. So
Right.
I would put it that way. Yes.
Dr. Venkatesh, over to you.
Yeah, good evening. See, as all other panelists was telling, the peripheral vascular disease is the third most common cause for the death in all over the world. As today we had a meeting discussed that one. So how to prevent this one? So now we are with the old tradition is the open surgery, which is proven is reliability. But at the same time, the newer techniques have come which we need to adapt according to the patient's benefit. See, whether the newer technology or open surgery or surgeries and bypass thing, whatever. So always you need to give the weight options of which one suits good for the patient. So that is the procedure. I mean, you always think about that one. So yes, there are most of the nowadays, almost more than 70% of the procedures done for bypass or vascular reconstruction or by endovascular thing because of a newer technology, newer balloons, newer stents, and the newer guide wires and done under local anesthesia. Most of the time, all these procedures done in local anesthesia without much risk to the patient thing. We need to remember most of the vascular patients they already have diabetic, hypertension, ischemic heart disease. So when you subject them to the major procedure, open surgery, yes, invariably they'll have anesthesia complications, they'll have surgical complications, everything. To minimize this one, we have adapted the new endovascular procedure, which is really good, and we should always first line treatment. You should try is endovascular procedure, which is suits to the patient very well.
Right. Right. Thank you. Now, this is my last question. And since this is Vascular Diseases Awareness Day, I want to understand from each one of you, and this is one message that you want to give out to how to enhance the awareness about vascular diseases, and also where should the push come from? Why don't we start with Dr. Prasad?
Yeah, definitely this being a vascular disease awareness day. So we are supposed to create awareness about the vascular diseases first among our own colleagues and also among the public, definitely. So first among our own colleagues, because this is I can say definitely newer specialty compared to any other specialty. And then sometimes many of our own colleagues will not be really knowing what we regularly and then really do. So everybody says minimally invasive, but definitely some people do not know that we do a procedure as for a cardiologist. Definitely, if they say he's doing angioplasty stenting, definitely they'll agree. But for a peripheral vascular surgeon, our own colleagues, definitely I'm sometimes sorry to say this also. So they'll not know we are the people who are trying to save the limb with minimally invasive techniques like angioplasty and stenting, instead of a big long bypasses earlier being done by cardiothoracic and vascular surgeons. So this is one first awareness to be created by the our own people in our own hospitals with the colleagues, what we work daily together. And then regarding the public awareness, definitely nowadays with the advent of technology, so if you with the younger generation, with the click of a button, they will have their phone in their pocket. Definitely, they get to know the information of their disease. But at the root level, where the patient do not have an access to a vascular surgeon, see in especially in Karnataka, so about 35 to 36 vascular surgeons are there. But most of them, I can say more than 90% of them are concentrated in Bangalore only. And then hardly about 4 to 5 are outside, either in Hubli or Mysore. So many of the other district level hospitals do not have access to a vascular surgeon at the time where it is really required. So this has to be taken to the root level, at least from the district level and then also taluk level places where the patient has got an acute limb ischemia, as I was mentioning earlier. So diabetes is there even in each and every village. There is a diabetic patient in each and every village. So there we have to create awareness regarding this disease of vascular diseases. And then we need to tell what exactly we are trying to do and then why we are here. We are trying to save the limbs first. So our motto is to save the limb and then save the life of a patient. So this is most important thing, to create awareness at the lower level of the society, then among our own colleagues. So then this idea of vascular disease awareness day or vascular day will be definitely fulfilled.
Right. Dr. Anup?
Most of what Dr. Rajendra Prasad said is going to be the common way of creating awareness. The problem right now is that half of our colleagues really don't know what patients should be sent to us. If they start to recognize that we are here to help, and results, when you treat a patient and their legs get salvaged and their wounds heal, then patients, doctors will start understanding the role of a vascular surgeon and start sending patients to us. Secondly, maybe brochures, booklets, when patients wait in the hospital, when they are sitting, you give them brochures to read, then they may get some information regarding what kind of diseases a vascular surgeon treats, what are the things that they need to look for, and when they should come to a doctor. Once they get to know, then word of mouth is what we're looking at. Information spreads from word to mouth to mouth. Particularly with media, so many now with computers, radio, all these should help get to like sir said, district level, taluka level, villages, spread out the information of what are the problems they could encounter, who should they be meeting, or which doctor they should go. This way we'd be probably able to help more people and spread the awareness.
All right, Dr. Rahul.
Carrying on with what Dr. Rajendra Prasad and Anup said, one thing which I would like to add here is coming in the cities, most of them will, if they will get to know through the internet or through the media. In the district and taluka places, regular sound bites or small videos about what we do in the local language, that needs to be circulated, as well as regular what we call as feedback to our referring physicians about whenever we do any interesting case or we do a challenging case. It is always better that we share it with them about pre-procedure and post-procedure results. That is one thing which would help. Second thing is we are missing out on a very important aspect here. We are, irrespective of the tremendous growth we have achieved in the past few years, we still are a developing country with a sizable population, or in fact, majority of the population which can hardly afford regular meals. So when it comes to that situation, it is very important that we do not refer the patients to multiple places. Anup said about that they should know when to refer to a vascular surgeon. See, the vascular surgeon and vascular and endovascular surgeon is sort of able to do the work of about 2 to 3 specialists. So it makes a huge impact on the financial aspect also on the patients. Whenever they have a vascular disease, if they consult a vascular and endovascular surgeon, the cross referral or accountability aspect too will fall in place. So that is something which I would like to insist. One is local language, and second thing is very important that we highlight that we are able to do the work of about 2-3 specialties together, so that there is less financial burden on the patients.
Right. Dr. Venkatesh, what is the one message that you would like to give?
See, as everybody says, one common thing is just create awareness, especially among the referring doctors. See, any patient vascular problem, they don't come to the vascular specialist directly. They go on with basically their basic physicians or general practitioners. So create awareness among them. In fact, this is a procedure. This is a practice we did almost 15 years, 20 years back. We used to go to travel all over the Karnataka rural areas. We created awareness among the general practitioners or MBBS doctors from the villages and taluk level. So that is what is carried through from that time. So still, because the people, the moment we say endovascular treatment, that is angioplasty or a stenting, whatever thing, the moment when you say like that, the first thing they say is, oh, cardiologist. So that we need to get rid of the mindset from those general physicians, or in fact, our corporate hospitals, many people, physicians, they think that an endovascular means is done by the cardiologist or something. But we are the one vascular surgeons here who train. We know the disease. We have seen the arteries, blood vessels, how it looks, how it is behaves. So we need to create awareness among the doctors regarding vascular surgery has to be done. Endovascular procedure done by the only vascular surgeons. Then patient obviously then they'll come, especially in rural areas. They'll go and they need to have more and more awareness about their disease patterns. That's all I can tell.
Right. Dr. Hemant?
Yeah, I think most of the points have been covered by all my other colleagues. There's not much to add. It all finally comes to awareness of the disease, especially amongst our colleagues who refer these cases to who get to see it. The patient, if he has a symptom, will definitely go to a doctor. The doctor there who's seeing the patient should know what the problem is and whom to refer to. And as said by my other colleagues, vascular and endovascular surgeons manage both minimally invasive procedures as well as open surgical procedures. they're in a position to handle both of these methods to optimally manage the patient. So this awareness amongst referral doctors, primary physicians, and even super specialists in corporate hospitals, many times they do mistakes. They don't pick up the disease early enough, they don't refer early enough, and patients suffer a lot because of that. So it's all about a sustained education campaigns amongst the public, amongst basic ground level doctors, as well as other super specialty doctors. That's got to create a change in the way these patients are going to be managed in future.
Right. Yeah. Well, we have deciphered a lot today about vascular diseases and their prevalence in India, and as well as the endovascular and vascular surgeries that are being done in the scenario of modern healthcare. And I'm sure there is lots more for us to learn, and we will do it some other time. But for now, I would like to thank each one of our panelists and viewers for joining us here today. Thanks a lot, everyone, for taking out the time from your busy schedules to do this. Thanks a lot. Thank you.
Thank you.
Thank you, Shubham.
Thank you.
Thank you.